Good afternoon. Thank you all for joining us today. First, we're going to hear from Dr. Don Yealy, UPMC's Chair of Emergency Medicine, who will update us on our restoration of essential care and what our data are revealing about the spread of COVID-19 in our communities. Then we'll hear from Dr. Rachel Sakrowitz, Chief Medical Officer of UPMC's ICU Service Center, and she's going to share how UPMC is prepared for the returning patients and how doctors have helped care for patients outside of our region. After our experts give their remarks, we'll take your questions. Dr. Yealy.
Thank you very much, and thank you for attending today. Last week, we shared the UPMC plan to ramp up testing for all of our patients without symptoms, starting with those who were scheduled for necessary surgical and medical procedures. This testing of patients who do not have symptoms, but still who might have COVID-19 infection, assures not only our individual patients, but our frontline staff, adding to the knowledge about how to best take care of each individual patient. Using our plans that exist to do things safely and using our testing, we can provide this essential care and do it safely. We don't want to delay necessary medical care. We don't want to make little problems into bigger problems. We don't want things to become life-threatening. Last week, Pennsylvania announced that hospitals like UPMC that have both testing and careful plans based on observations could resume not only essential care, but they could begin preventative and other elective care. That would include colonoscopies, minor surgeries, blood tests, and cancer screening. We appreciate this step, and we think it's the right thing to restore care with appropriate testing and with safeguards. We want to address the backlog of postponed but medically necessary care. As we've discussed, UPMC surgeries were down 70% compared to the pre-COVID period, but they've been growing over the past week, with the first 10% of that drop already returning. We expect most of those patients to return over the next month. We haven't had a single asymptomatic patient in Western Pennsylvania test positive for COVID-19 as part of our strategy to bring people back. In addition, we continue to have a stable and a manageable number of hospitalized patients with the COVID-19 infection, and we're using only 2% of the 5,500 hospital beds across our system. Our return to essential care has happened against a backdrop of declining numbers of new COVID-19 infected patients in our hospitals, in our communities, and statewide. We always prepared for the worst. We cared for those who needed the care, and we used our experiences across all of UPMC to guide us. A few stories can help us understand why it's so important for both our patients and our healthcare providing teams, how stories of disruption affect people over the past few months. Since we made our announcement last week, we were able to insert a cardiac stent in a gentleman who was struggling with heart issues. He had to postpone his procedure in March. He and his wife had moved to Pennsylvania a little before the pandemic broke out. He was here to help care for his in-laws, and we were able to get him back to care for his family by doing the procedure. Another one of our doctors was able to save the vision of a patient, a retired military veteran with nearly 2 decades of service, who had lost some sight due to a pituitary tumor. Neither of these were truly emergencies. Some might say it was elective care because it was scheduled. We actually like to think of it as necessary care. Further postponement could have caused harm. We were able to comfortably treat both of them because our asymptomatic testing, that is, testing of people who had no reason to suspect COVID-19, showed that they were not carrying COVID-19, so they wouldn't suffer any unforeseen complications from the disease after surgery, and they didn't pose a risk to our healthcare providers by coming in and having the procedures done. In 1 week's time, we expect the Commonwealth to broaden the reopening efforts. We seek to help inform that with our testing and our experiences. The plans will lift many of the COVID-19 related restrictions for counties and regions, and they'll base that in part on disease prevalence, both symptomatic and asymptomatic disease prevalence. I'm happy to report that in Allegheny County and in the vast majorities of counties that UPMC serves in Pennsylvania, that includes Erie, Lycoming, Somerset, and Blair counties, the number of COVID-19 positive cases have been declining. In Allegheny County alone, we're seeing a rate of new positive cases of less than 30 per 100,000 people over the past 14 days, and that's a downward trend. We expect that on May 8th, we'll still be below the 50 cases per 100,000 that the Commonwealth is looking for to consider loosening those restrictions that exist. We expect to reach that same rate across virtually all the counties and areas that UPMC serves, with the possible exception of South Central Pennsylvania. Let me turn now to antibody testing. It's a topic that's in the news, and if it's done correctly, can provide a better understanding of the prevalence of the disease, as well as the impact in Western and Central Pennsylvania, as well as in New York and Maryland. Antibodies are proteins that are produced by your immune system in response to an infection. They can help you fight the initial infection, and they also can help protect you if you're exposed to that same infection in the future. If you had COVID-19, you should have antibodies in your blood if you recover. There are many tests available that look for these antibodies. Some are much more reliable than others, and many are not much better than flipping a coin. Our UPMC clinical laboratory team is assessing all the available testing options, including our own developed test and those of other commercial partners. We are building our capacity to not only test, but to have the most reliable test that answers, were you exposed and are you immune? We're already using it in some of our patients to learn more about the tests, and we will soon be offering antibody testing to all of our patients alongside of our pre-surgical virus testing capabilities. It's important to note that antibody testing can help not only individual patients understand where they are with the disease now and in the future, but it can help policymakers and public health officials make much more accurate estimates about the disease prevalence and the mortality rate. Right now, many of you hear alarming death rates that are really case fatality rates. That is, the number of people who were known to have the infection and the number who died from that group. In New York and California, where some antibody tests have been used, we've learned that way more people, far, far more, have actually been exposed to the infection without any knowledge of it. That makes the overall death rate much lower. Many people just didn't feel sick at all and recovered without difficulty. The New York and the California studies found that the prevalence of antibodies ranged from 5% of the population to up to 20% of the population, and this is in people who did not know they had any illness. Let's take a look at what that could mean here. Let's assume that the social distancing that we all did was effective, and the frequency of antibodies is, for the sake of this argument, fairly low. If Allegheny County had 3% of people that were exposed to the infection and recovered, that would mean nearly 36,000 people had the virus, but really no illness from it, never knowing that they had it. So the true mortality rate of COVID-19 from those estimations would be about 0.25%. That is 94 total deaths divided by 36,000 people who had either clinical infection or an infection that they never knew about. That is much different than the case rate mortality that you've heard of as high as 2 or 4 or even 7%. There is a big difference between 0.25% mortality and 7% mortality. Finally, while it's known that there are 1,289 positive COVID-19 tested patients in this example, it also means there's 34,700 people who are asymptomatic who may have already developed antibodies to COVID-19. This is why we want to do broader testing to try to understand more about the prevalence of this disease. COVID-19 can infect almost anyone. The biggest challenge is in our most vulnerable population, and that's particularly true in the elderly and in those who are immunocompromised. Sadly, the majority of deaths in our regions, whether it's central Pennsylvania, New York, Maryland, or even Allegheny County and western and northwestern Pennsylvania, are associated with the elderly, and particularly those in nursing homes and people with an average age of 80 or above. So what is UPMC going to do about this? Well, in addition to our expansive testing, that is, anyone who's symptomatic we will test, as we've been doing for months. And now with the addition of testing in asymptomatic patients and planning antibody testing, we will continue to study what novel treatments might help those who are infected using our novel and international REMAP trial that Dr. Angus told you about weeks ago. UPMC is also going to focus on the most vulnerable population, that is seniors, wherever they live, particularly those that are in a nursing home or a congregate facility. We are developing innovative ways to diminish the effect of COVID-19 with targeted treatments, even before a vaccine becomes available. This will include reliable antibody approaches and other treatments that you've heard of, like convalescent plasma. By taking this highly targeted approach on identifying who has the illness, both with symptoms and without, and focusing on how we protect the most vulnerable, especially the elderly, those in nursing homes even more importantly, we can inform policymakers and public health officials with respect to opening up society, opening up the economy, and protecting as many of our citizens as possible. All of my UPMC partners are dedicated to our patients and our families, and we're wrestling with the effects of this illness and this pandemic. We've seen the effect of it in very real ways. We want to help everyone who needs care, including COVID-19 care and those who need their essential care and their preventative care. We want to do this smartly and caringly, and we want to test, we want to learn from what we experience, and we want to share that with the region, the state, and the country. Dr. Rachel Sakrowitz will now tell you more about how we will provide care for patients in the ensuing weeks.
Thanks, and good afternoon. I would like to take a moment to reflect on our work over the past months and how those efforts will serve to strengthen our path forward. Months ago, we were preparing for the worst. We closely studied the rapid rise of COVID-19 in places such as northern Italy and New York City, and we prepared the UPMC health system for scenarios that we prayed would never come. We marshaled our resources, counted every last ventilator, figured out how to double our ICU capacity, and made long-term projections regarding our supply of personal protective equipment. We also saw tremendous growth in the demand for our telemedicine resources and services. In response, we built robust telemedicine infrastructure and leveraged this capability to continue providing needed care to our patients safely. Our telemedicine visits jumped from 250 per day in early March to nearly 9,500 per day last week. That's a 38-fold increase. Thankfully, the feared surge of COVID-19 patients has not materialized here. The disease still made its way into our communities and healthcare settings, and we expect to be treating patients with COVID-19 for the foreseeable future. So now, we're making different preparations. We are preparing our hospitals and teams to quickly return to providing expert care to the vast majority of the people we serve who do not have the disease, while tending to those with COVID-19 simultaneously. We are fully committed to keeping our patients and healthcare workers safe as we resume the full range of our world-class health services. Right now, that means testing asymptomatic patients and developing a meaningful antibody test that is actionable, thoughtful visitation and entry screening policies, maintaining specialized units within our hospitals dedicated to COVID care excellence, continued vigilance over our levels of personal protective equipment, contact tracing of any new COVID-19 case in our patients to stem spread, continued integration of our clinical operations and research efforts throughout our system, including our skilled nursing facilities, and providing data to our public health partners to guide decisions outside our walls. We are working closely with our doctors, nurses, and other clinicians on these plans to safely offer the care our patients rely on us to provide. We have regular virtual meetings and town halls where we make sure concerns are addressed and all ideas are considered. We've also been communicating with our patients who have been almost universally eager to return. We are deeply honored by the trust that they have in us and look forward to building on the care that we've resumed in the past week. You've heard us talk about how we prepared our hospitals for the worst, which thankfully has not materialized regionally. Of note, the very same preparations that enabled us to provide care safely here also enabled us to lend a hand and serve patients and care teams in New York City. You may have seen a full-page ad last weekend in the local newspaper. This ad was a very touching surprise to me and my critical care colleagues here at UPMC. In it, New York Presbyterian, a health system in Manhattan, thanked our doctors for helping them. And while nobody at UPMC expected recognition, I do want to share the story behind it. As everybody knows, New York City has been very hard hit by COVID-19. Many of their doctors were called to step into roles and situations that they didn't expect. Many clinicians, such as surgeons or hospitalists, who do not typically work in ICUs, are caring for critically ill patients. So as we rapidly expanded our telemedicine across the UPMC system, we realized we could also provide tele-ICU consults to help overwhelmed providers elsewhere. Our doctors sitting in Pittsburgh, for example, could partner with teams in New York City to care for ICU patients. We reached out to our colleagues in New York City and offered our support. New York Presbyterian was immediately receptive, and we quickly implemented a tele-ICU outreach program. Our UPMC critical care physicians volunteered their unpaid free time 24/7 to help in whatever way was needed, whether it was troubleshooting a ventilator, adjusting a medication, or even serving as a sounding board for various care options. I tell you about this because we believe this is yet another way that our medical community came together during this pandemic to solve problems and support each other. The tele-ICU model we established with New York Presbyterian can be replicated nationwide. Finally, I want to share a number that encourages me each day. The total number of people recovering from COVID-19 continues to grow. Early this week, UPMC discharged its 200th patient, and today that total is 234. This is very good news. It means that people are getting better, and we're all on the right track together. Thank you.
Okay, thank you, doctors. And now we'll take questions from the media, all of whom are joining us remotely online. To ask a question, you'll have to go to the participants icon at the bottom of the page and press the Raise Your Hand button. That will put you in the queue. I will read your name and your line will be open for you to ask a question. Please make sure to unmute your microphone on your end so that we can hear you. We will try to call on as many different media outlets as we can in the time we have allotted. So I have a few email questions, and there's actually several emails, all the same theme. It has to do with we've been hearing a lot about nursing home deaths, and people want to know, what is UPMC's experience with its nursing homes?
UPMC oversees 14 different either nursing homes or skilled nursing facilities, and we've not had a single patient in those that fall directly under UPMC test positive for COVID-19. Now, in our hospital system, elderly patients, and particularly those that come from a skilled nursing facility, make up a large chunk of the people who have suffered death. And that's for many different reasons. It's why we want to focus not only on our own skilled nursing facilities and nursing homes, but to help the region deal with this very vulnerable population. You do that through aggressive identification of who has infection. We've done that already. By aggressive activity with both the patient and their providers to make sure that they're isolated, safe, and have all the best care at their facility, try to keep them there if possible. And then when they need hospitalization, and make sure that they're getting the highest level care that can happen.
I would also add that we have the opportunity to use the telehealth and telemedicine infrastructure that we built for COVID-19 to deploy care and expertise to our extended care facilities and patients there, alleviating the need for patients to travel, if that is difficult, to an inpatient facility or other care setting.
Okay, thank you. We'll take a question now from the media. Paul Goff, Pittsburgh Business Times. Paul, go ahead.
Thank you, and thanks for doing this again. Dr. Yuli, can you talk a little bit more about what you're doing to and what the system is doing to kind of get back to a more regular pace? Obviously, UPMC, a lot of our healthcare providers, most hospitals have had to take really large financial hits in this situation with not having elective surgeries. And tell a little bit about kind of when you think you might be back to normal and what you might be thinking about as if there's another wave of this going down the line.
Well, it's hard to predict whether or not there'll be another wave. What I suspect is that COVID-19 will be a part of our experience treating patients for an extended interval, months to maybe years. If you think of other types of infections, they may come and go, but they never completely go away. And we will learn to deal with it, and we already are learning to deal with it as part of our ability to provide care for everyone. We never completely stopped essential care. It was one of the differences. We were clear that not all scheduled care, which is what the term elective generally means, was unnecessary. And we tried to provide necessary care all along, and that was completely within both Commonwealth and federal guidelines. Some care was delayed because patients' desires, between the combination of a conversation with a patient and a physician, we are now using those known delayed care episodes to reschedule that care right now. We will essentially use the same process that we did to dial things down to bring them back up. We don't have any specific timeline or target number of cases. You may have suspected that or heard about that, but it can't be. And I suspect that the new normal won't look the same as it did prior to COVID-19. We are going to learn about what care can be delivered in different formats, and we're going to put that to use. We can't go back in time. Our goal is to continue to move forward and deliver the best care possible to all that need it.
Okay. Next question, Michelle Ganassi, Somerset Daily American. Michelle.
Yes, thank you for taking the time today. I was curious, there's been a lot of conflicting reports on what it really means to have antibodies, whether that will help prevent you from getting it in the future or whether they don't stay in your system for a long enough time. Can you talk a little bit about what you guys have learned about these antibodies and what it will mean as we go back to whatever the new normal is going to be?
We think there's still a lot of opportunity to learn more about antibodies. As we talked about it, those are proteins that your immune system make to fight the current infection, and your body can, the next time around, if it's healthy enough, respond even better and you maybe not have the infection. The current tests tell us in general about was there a previous exposure. They do that reasonably well, but they don't tell us if they're the kind of antibodies that kill the virus and come back later on should you be re-exposed to the virus. That's the activity that we hope over the next few weeks that we can develop that kind of testing either on our own platform or together with commercial platforms to help answer that question. No one can tell you that right now. The best they can tell you is a certain number of people have had some circulating antibody around, but whether or not it actually is protective in the future, we simply don't know yet.
Okay. I have an email question. This probably goes to Dr. Sakrowitz. You've helped some hospitals in New York City, including New York Presby, Are you helping any other hospitals right now?
That's a great question. Currently, our outreach tele-ICU program is deployed to a number of different hospitals in New York City. We are very open to deploying that program elsewhere if the need exists. I would add that we would also be open to helping other systems or hospitals develop their own tele-ICU program for use within system or for use for outreach programs locally.
Next question, Jamie Martinez, Tribune Review. Jamie, go ahead.
Hi, can you tell us a little bit about what the timeline might look like for rolling these antibody tests out? And then related to that, can you also just tell us a little bit more? Are these the same tests that are currently being used for the convalescent plasma screenings, or would it be a different test, some combination, if any other details are available? Thanks.
Those are all good questions. So there are commercially available antibody tests available right now. We do use them to help as part of the convalescent plasma screening. Convalescent plasma is you take part of the blood from someone who has recovered from the illness, hoping that the antibodies there, which are more diffuse, maybe not quite so specific to COVID-19 alone, you give them to sick patients and help them recover more efficiently or better. We think that in the next weeks, and that's 2 to 4 weeks, that we'll be able to have progress on a better antibody test that answers that immunity question. I can't give you a more specific guideline or specific timeline from that.
Yeah, I would add that we are leveraging our REMAP program to really obtain more knowledge about all of these therapies. And so I believe last time Dr. Angus spoke, he mentioned that the 2 treatment arms currently being studied through the REMAP program are hydroxychloroquine and steroids in critically ill patients. And very soon we are adding 3 additional treatment options to that initiative, including convalescent plasma, vitamin C, and anticoagulation. So hopefully we should very rapidly be able to accumulate knowledge that could inform these conversations.
And one of the things we'd like to talk to you about in the future, again, weeks to months ahead, is the ability for us to create a very specific antibody that would protect individuals in lieu of a vaccination. That's not ready right now, but it's one of the things that we work on as a world-class academic medical center that can really change the game in the approach to COVID-19 illness and infection.
Okay. So again, to ask a question, you have to go to the participants icon at the bottom of the page and press the raise your hand button. That will put you in the queue. We will read your name and your line will be opened for you to ask a question. Next question, Dave Templeton, Pittsburgh Post-Gazette. David, go ahead.
Yeah, you generally answered my question already, but are you also looking at remdesivir? Dr. Fauci said that's shown some progress. Why aren't you looking at that?
So as you know, and as you probably heard, there have been recent communications about studies about remdesivir, some recent hope that we may have an optimistic path forward in terms of reducing the duration of illness with COVID-19 responsive to remdesivir. I think right now we are thinking about REMAP as a way to learn about all potential therapies that might be effective in COVID-19, and remdesivir would certainly be on the docket for future study.
It's very early on in the remdesivir story now. As you know, there are really 2 recent trials, one that showed no benefit at all, another one that showed a modest benefit. And we want to learn once the full set of data are available, and we want to do this smartly. There's a strong desire to do things in the middle of a pandemic like that. I think what you expect from us is to not just to do things, but to do the right things. And that's where being careful, thoughtful, and using a novel platform like REMAP can really be helpful not only to the people we treat here, but our region and the country.
Thank you. Next question, Joe DiStio, KDKA. Joe, go ahead.
Yeah, hi, for Dr. Yealy. I wonder what your view is about whether UPMC is ready for the partial resumption of economic activity. As you know, the governor is going to make an announcement tomorrow. And presumed increased number of cases that may bring. And I wonder if the state has asked you about that.
When we began to expand our essential care, it was always essential care, we were in close contact with Secretary Levine and the governor. So there was complete transparency on our behalf about the desire to do that care that's important for the people that we serve. We will continue to monitor what's going on in the community, not only from infections, but from those who don't know that they're infected. I just shared some of that information with you, and we will use that to guide not only the care we're delivering today, but how we plan for the next few weeks. It's our obligation to see how things go as the rest of the Commonwealth begins to return to something that looks more normal. I don't know what it'll be. Just like last time, we will prepare for the worst, hope for the best, but respond to what we see, and we will use all of our tools to make sure that we're looking as hard as possible for the realities here in central Pennsylvania, western Pennsylvania, New York, and Maryland, all the communities that we serve.
Okay. Thank you. Next question, Bill Kibler, the Altoona Mirror. Bill, go ahead. Okay. Remember to unmute your microphone after we open your line so we can hear you. Let's go to the next question. Rich Lord from Public Source. Rich.
Thank you, Paul. Just to ensure understanding, when a patient comes in for a non-COVID related appointment or procedure and they are asymptomatic for COVID, will they all get a virus test and eventually an antibody test? And do you consider these to be long-term propositions or short-term measures?
So right now, if you come in for a scheduled procedure, which could be surgical or non-surgical, you will get a virus test. If you come in for scheduled other type of care, there will not be testing this week. We will be expanding our testing to make sure that all who come for any care get a virus test. Additionally, with that expansion, and when the antibody test is improved, which we just talked about, we will begin to offer that too. So think of it as concentric circles building out. First with people who are having procedures done, next with those who are coming in for any type of care and our healthcare workers, and then eventually using antibody testing.
I would add that it's very reassuring to know that of all the 500 patients we have tested in our system who have been asymptomatic, only one has been positive.
Okay, next question comes to us via email. Is UPMC Children's Hospital safe to provide procedures and surgeries? Do you have a lot of COVID-19 cases at Children's Hospital?
So every UPMC site is safe to come to for care. One of my biggest concerns as an emergency physician is the risk that people take by avoiding the hospital because of the fear of COVID-19. That fear may put you at more danger than the actual reality of COVID-19. The hospitals are very safe right now from all the reasons that we've described. Children's Hospital in particular has no current cases of COVID-19 that are inpatient, and throughout the entire pandemic have had no more than 4 patients that at any moment in time had been within the hospital boundary. All their patients have done exceptionally well. Children's and the rest of UPMC are safe to come to for care, and I don't want us to have similar experiences that we've heard around the country where children have had really bad outcomes because of delays in seeking care based on that fear. It's safe. Do the right thing.
And I would just add that all of our teams, our physicians, our nurses, our partners are educated and trained in how to keep patients who don't have COVID-19 safe, how to take care of patients safely with the disease, and how to manage that so that we can take care of our whole population. So I would echo that you should feel safe coming to UPMC, knowing that we will be able to take care of you here.
We had a bit of a technical difficulty with Bill Kibler, the Altoona Mirror, but he had emailed us a question, and I'll ask that now. Has UPMC gotten any pushback from the State Department of Health for starting a week early on the elective surgeries and procedures?
So this is an important time to make a distinction. We always provided essential care, And the care that we've been delivering throughout the entire COVID pandemic, and including last week, was for essential care, and that was always permitted. Secondly, as we discussed, we notified both the Secretary of Health and the Governor of our intentions and the thinking behind it. And we think that they were appreciative and they were completely aligned with what eventually happened from the government side. So there's been no pushback, and we are doing what we said we would do, is provide initially the essential care and also do it safely, smartly, and use that knowledge to not only treat our patients best, but to help inform the community and the government.
Okay, we have a follow-up question. Jamie Martinez, Tribune Review. Jamie?
Thanks. Can you tell us when the antibody testing starts, what is the process going to be like for sharing that information with the county or the state, and how might they use that data?
We share all of the testing that's done right now, whether it's viral testing or antibody testing, with the county health department, who then shares that with the state. We expect to continue that. We have ongoing contact with the Allegheny County Health Department and their medical director. I expect that to continue, and we'll have an ongoing dialogue about what we think the impact of these results are, and help together craft the best interpretation and the best plans.
Okay, another follow-up question, this one from Paul Goff, Pittsburgh Business Times. Paul, go ahead.
Thank you. Can you expand a little bit on the measures you're going to take for the vulnerable populations, like nursing homes? You talked about the testing, this highly targeted approach. Are you going to offer this to within the communities that you serve?
Yeah, I think it's a multi-pronged approach. It starts with ensuring that there's adequate and high-level medical direction at the facilities. We obviously have more control over UPMC-run facilities than others, but our experts have been leaders not only in the region, but in the Commonwealth and in the country, in helping to guide how it is these facilities can do that important care and keep people safe in the best way. Next, we will be expanding our testing over time, as we've talked about, obviously with symptomatic patients, making sure we identify them, that once they're identified, they have the appropriate treatment, isolation, and protection for their staff so that it does not become essentially a bigger spread. And then also making sure that when people need to be transferred, they come to the appropriate facility and they get the best level care. We've had that experience, the Western Pennsylvania experience. Dr. Sakowicz shared with you the number of people who have had the illness, been hospitalized, and went home is actually amazing. Unfortunately, elderly patients and those at nursing homes still make up too much of those who die. We can do better, and we will do better.
And one of the advantages of being a large and integrated system with so many resources from a clinical care perspective, from a research and academic perspective, from an operations perspective, is that we can deploy those resources throughout our system, not limited by patient location, either geographic or care setting. So a patient in a UPMC extended care facility can access the same interventions and resources as a patient in one of our acute care hospitals.
Thank you. We'll try Bill Kibler again. Bill, you have a follow-up question. Go ahead, Bill. Okay, still having technical difficulties. We have time for one final question, and I'll go to an email question that was sent to us a little bit earlier. With your calculation on the death rate of COVID-19, should we be more worried about this disease than the flu?
I think what I would say is you should be worried differently. Both the flu and COVID-19 can strike anyone, and both of them have a disproportionate effect on the elderly, those who are immunocompromised, and in particularly the elderly that are in a nursing home facility. Their fatality rates differ, but no one wants to have anybody die from either one of these illnesses. So I would not think of it as more or less just two different illnesses that share some features, but have some distinct differences. We're trying to grow the tools in the box that will help us dampen down the effect of COVID-19, and we've been doing that with influenza for years.
Yeah, as with influenza, we expect that COVID-19 will be part of the disease burden that affects our population and our communities, that it'll be with us going forward, much like influenza, but where we will be able to take care of the full spectrum of medical problems, as we always have with influenza and with COVID-19.
Okay, thank you. And that concludes the time we've allotted for today. Thank you all for attending. In about 45 minutes, we will email the media attendees a link to download high-definition footage of this entire press briefing, which we, of course, encourage you to use in your news reports. We plan to continue holding these regular updates for media as long as there is a need. In the meantime, reporters with questions are encouraged to contact our UPMC Media Relations Department at upmc.com/media, and please follow @UPMC News on Twitter for frequent updates. Thank you very much.
Thank you.